or I can boost it on my phone and we'll set things up. It's because I'm down here at PSP Central Office and trying to coordinate working off my own laptop at the same time that we're running this on a PSP computer. So welcome, everybody. This is the update for the COPD heart failure learning plan. Of all the modules, I suspect that this is probably the one that most have had least experience with. I think that there has been most of the work concentrated in interior health and especially on the COPD portion of the module. And to that end, there's been very good feedback from the respirologist that has been involved with helping do the update from interior health. And for heart failure, Dr. Sean Virani from down here in Vancouver has been involved with helping do the updates. There hasn't been particularly much RST feedback or requests for feedback from you folks. So I hope that we can use what we're displaying and demonstrating today, as well as those of you that might have had some experience, to be able to provide some feedback for us for anything that we might have missed, should consider, went well, didn't go well, or people are requesting for changes. So with that, I will dive in. First, just before we start, any questions on what today's agenda is going to be, which is all focused on the COPD heart failure learning plan and module presentation? Hearing nothing, we'll start in, as we usually do, just looking at how this is being set up. As with all the modules, we are now being diligent about making sure that we provide the overriding goals for the program, what the specific learning outcomes are, and key messages, as well as being able to provide you learning session outlines that demonstrate not only the suggested content for learning sessions 1, 2, and 3, but also the content for the 2 action periods. That includes instructional plan that breaks down each of the 8 outcomes into how to assess, how to teach, and the resources required for this, as well as where those outcomes are applied in the context of the overall framework, with the outcomes, learning objectives targeted in each learning session and the activities that might be associated with them. So that being said, we'll just dive in, looking at the goals. And I think one of the key things with COPD and heart failure is to improve the confidence and comfort in family physician diagnosing and treating patients with COPD and heart failure. And the reason, if you're looking at starting with the why, key, and we'll address that in the presentation, is that both heart failure and COPD are both typically under-identified and under-diagnosed, and that's the key message that relates to that overriding goal. And the other interesting thing is that we know from a lot of the work that's been done is that most patients with mild and moderate heart failure and COPD are and can be managed in primary care very effectively. And finally, the interesting thing that a lot of physicians may not understand and may confuse their actual approach to a patient is that heart failure and COPD can be comorbid or exist in the same patient at the same time, since essentially some of the things that are precipitating factors for both of these conditions, i.e. smoking and hypertension, are things that are common to patients, and so set patients up to develop both of these conditions at time. We also know that there's been a lot of medication changes over time, and especially since physicians were trained. So being able to expose physicians to a stepped approach in both the treatment of heart failure and the treatment of COPD with exposure to the current thoughts around current medications is going to be quite key in this module. This is somewhat a departure from other modules such as adult mental health, chronic pain management, child and youth mental health, where medications were a component of but not necessarily a focus. In COPD and heart failure, medications become a much more prominent part of the management and balanced, of course, with the self-management principles and goals. So both those things are highlighted in this module. As you can see from the learning outcomes, we're looking at tools to identify patients and to first screen for and then actually diagnose or identify the evidence-based strategies for management of those conditions, and to be aware of the education tools and resources, as well as the referral patterns to both allied health and specialty care for both of these conditions. People may ask, why COPD and heart failure together? And at first, when we were revisiting the update on this module, the thought was that possibly we could unbundle them. Very quickly, we realized that if you're looking at these patients from a clinical context, from an approach with how they present with their symptoms, the classic way with both these patients presenting to a physician office is shortness of breath. And really, there's a decision tree that happens when somebody comes in with shortness of breath that the physician moves through that includes both COPD and heart failure as primary elements of the differential diagnosis. So it's because of that decision tree starting point of shortness of breath, and because this condition is so often comorbid in patients, the decision was to continue on with both these conditions being presented in one module. Now, I will add in that Bill Upward and I, Bill is the education consultant that's been working with PSP, have been tasked to look at COPD and heart failure module as a first instance of how we might take a module and break it down from the three and a half hour big learning sessions with 2 action periods into chunks where there's a deliberate attempt to have 1 to 1.5 hour learning sessions with some of the content of either COPD or heart failure or the combination of both, and use it in a series of small learning sessions for continuous learning rather than the classic way of doing the PSP modules. So stay tuned. We will have more on you with that, and that's coming further on down the line. And the context of that, of course, as well will be around chronic disease management and fitting in with patient medical home, some of the tools that will be used for that, which will, I hope, include being able to look at physicians' data for panel management, and also include such things as common or shared care plans as a component of chronic disease management. More focused attempt to have people working on self-management goals and patient wishes as part of the common or shared care plan. So that's just an update on where we'd like to take some of this material and how we'd like to move along in the future. And hopefully a way that we might modernize our whole approach with the modules, and that we could offer multiple ways of being able to transfer knowledge and have an impact by being able to implement and sustain what we're teaching through newer education modules in small group learnings rather than more traditional in the way that we've approached things with the large modules. That's not saying that we're discontinuing them. I'm just saying that that's the potential next step. So I'll pause there just to see if there's any questions on our overriding goals, the outcomes, key messages, and my comments around where we might be going beyond modules with this whole process. Any questions? Okay, so moving on. As you've been familiar now, if you've been attending these sessions with the adult mental health or child and youth mental health, we have the learning session outlines with learning session 1, 2, 3, and action periods in between. There's been some thought into how we were going to do this and what content is included in each session. Seeing that it is a shared care model and that we're talking about two separate conditions, the focus in the first learning session is an introduction to the whole concept and an introduction to both COPD and heart failure, and how we might be looking at integrating this into a shared care module or model in the future, as well as introducing PSP and the whole process to those that haven't been exposed to it before. Key to this, to trying to apply adult education principles to the delivery, is that we're being very intentional about wanting audience participation and providing the time to actually present didactic material, as well as people to have discussions or involved sessions where they're actually participating in working through problems or talking and having discussions. And I'll get to that a little bit later about some of the actual tools that can be used in that audience participation piece that Bill has been very helpful with. So where you see in each of these learning session outlines a piece such as there is in COPD 101, there's some suggestion as how much time breakdown is didactic and how much time is broken down for questions in each of those pieces. We hope that in the action period time that beyond getting process data around how many patients are being tried out with COPD-6 device, or patients being referred for testing, imaging, spirometry testing, echocardiogram, that we start looking at gathering or helping the physician gather more practice-relevant information. So some of the work that you're doing now on panel cleanup will link into panel management through modules. And in panel cleanup, for example, with this module, having a clear idea of the patients in the registry that have COPD and heart failure respectively, and that those are properly coded and in the problem list, will be something that will be helping support the physicians in being able to develop in their practices. Once that's done, we hope that this is an opportunity for people to start looking at that information and data And beyond the things that we're asking them to do in the action periods that are really quite process-orientated, as mentioned, we're going to be hoping that you can work as coaches with them to start looking at that information and say, you know, I wonder how many patients that have COPD are still smoking, and what am I going to do about that? How am I going to recall them? What kind of information might I give them? How can I document referrals for smoking cessation and the success of what it is that we're trying to do with patients? As an example of panel management. Heart failure might be having patients record what their daily weights are and how they're going to do that at home, and how many patients are successfully doing that, and a feedback mechanism for that reporting back to the physician as to how well their education is transferring to the patient, and the patient actually starting to do some more self-management. So those are core pieces that part of what Kelsey and I have been working with each of the EMR vendors is to say, you know, how can this information be recorded in the EMR so that the education materials, the resources, and the data entry points are all available in the EMRs. So we're hoping, as has been demonstrated by many of you, that having pre-module visits where the EMR templates are actually available in each of the EMRs, and that the physician knows how to access them as well as the MOA, and that workflows are set up so that those EMR templates, those visit templates, are available, being used, data is being recorded, and the physician and the RST coordinators and coaches understand how they can access the reports and the dashboards, if they're available, for those reports and viewing that data in a meaningful way. And you can work with the physicians on that. So action period 1, as far as what PSP is interested in, is looking at developing those registries and doing some process measures, looking at the use of the COPD-6 device and the referral patterns that physicians are using to request further diagnostic tools to be able to confirm diagnoses for both heart failure, which is using echocardiogram or MRI or other means to look at what we call the ejection fraction, which is how much the left side of the heart is pumping out blood, how well it's doing that. And there is a threshold below which we say when a heart isn't pumping efficiently, that is a diagnostic feature of heart failure with reduced ejection fraction. And similarly with COPD, the diagnostic tool to confirm COPD is called spirometry, which is basically one of those lung tests that you breathe into and all sorts of measurements come out. And the key one is a ratio that's called FEV1, the amount of air that's pushed out in 1 second over the a total amount. And that's a calculation that gives a number, a fraction, that again is used as a threshold to determine whether somebody has mild, moderate, or severe COPD. So we have a screening tool for COPD that's not diagnostic, which is the COPD-6 device that is key in the first session to teach people how to use and set up a process, a workflow process in the office on how that's used. Learning session 2 starts diving into more medication management, specifically for COPD and heart failure, and also getting into patient self-management tools. So looking at whatever tools you're comfortable with and that you're familiar with in being able to teach around things such as motivational interviewing techniques, brief action planning is always our fallback, and other tools that might be used as part of self-management which is blending in, of course, into tools, literacy, language that are used in patient medical home and chronic disease management in that as well. And we'll dive a little more deeply in learning session 2 into the shared model of care, looking at how the specialist fits into that model, the referral tools that are needed for that, and also the allied health professionals that are so key in supporting the patient with COPD and heart failure. Action period 2 is really focused on documenting some of the specific interventions. So again, it's many process measures, looking at intervention with smoking, patients with exacerbation or flare-up plans for things like COPD or heart failure, and documenting that there's a medication review process in place. So the expectation from PSP is that those things will be done. And just to reiterate, the understanding is that while those things may be important for PSP to document and understand that they are getting through to the physician, what the physician may be interested in is something very different. They're looking at those measures that relate to practice improvement, and those are things that are part of panel management that can be a more flexible ad hoc approach by the coaches based on what the practice needs and interests are. Finally, in learning session 3, more of the focus comes back to, again, looking at the shared model, understanding how COPD and heart failure can work together in a comorbid patient and how they have to be dealt with. Some of the optional items might be looking at end-of-life issues with those patients, some of the palliative approach that differs from the standard palliative approach with people who have, say, cancer. And an example of that is in heart failure. Many patients may have devices that are implanted to help regulate heartbeat or shock the patient's heart if it were to stop. And how those devices are dealt with in a palliative care situation is something that is interesting and different. And then, of course, the usual in PSP is planning for sustainability and wrap-up. One of the things that we hope and that leads into the work that we're doing around patient medical home is that in the past, where this has been an end to a module, that in the future, this is a jumping off point, that these relationships that you are developing with physicians that haven't been exposed to PSP, or that you are reestablishing with physicians that have been involved with other PSP modules, might be then continued by the work that you're doing here, and to start encouraging an approach that is reflective, that involves using small group learning sessions for topics other than those that we are presenting through this module. So we hope that it can be used by many of you as an access point to a more quality improvement approach, and to start practices thinking about patient medical home. Even though it's not labeled as such, it actually is composed of many of the elements around shared care, around self-management, patient goals that are key and foundational to patient medical home. So again, I will pause to see if there's any questions or comments out there on my brief overview of the 3 learning sessions and action periods.
Hi, Bruce. This is Ranjit from Fraser Health.
Hi, Ranjit.
Hi. I have a question in regards to, well, what I'm doing right now. I'm in the process of talking to my respirologist and cardiologist to prepare for my shared care module at the beginning of November. And I met with them yesterday, and the number one question that the RT had was, sorry, the respirologist, was he was looking for evidence for the COPD-6 tool. He said, where is the evidence, the rationale behind using this particular device? And that's what I was going to email you about today, and luckily we have the call this morning. So I just thought I'd ask you that question, if that's okay.
Perfect. Yes, and when we actually developed this course and with the input that came from the respirologist involved in there was evidence for the COPD-6 device to be used, and this is key, as a screening tool. So we will get you that material, and I believe we have it somewhere in our archives, and make sure that we get it out to you. So Kelsey caught that with Ranjit that was interested in that. And anybody else that's interested in that, what we'll do as well with that is make sure that we post it on our SharePoint site and in our website, so that there is RSTs have ability to access that when that question arises. But I think a interim answer to that question certainly is that in a context of a practicing physician's office, what else do we have available that we could use as a screening device that might then suggest we have a patient that we could refer for the gold standard, which is spirometry. So that would be a question to take back to the respirologist that is asked that question. And
so
we
I
would
did
love
bring
to have
that
the
question
answer.
up.
Good.
And he said that there's so many clinics throughout Fraser Health, and physicians aren't being compensated to use this device, and they're not doing it correctly. And he also stated that the respirologists don't use the COPD-6 device, so they couldn't really see why we were teaching something or asking them to teach something to the GPs that they themselves don't use.
You know,
so
I think fair enough, and maybe, and I will just now speak from my perspective. I use a device to look at moles that specialists don't use. It's a little device that I saw in CSI called a ProScope, and it plugs in by a USB port. I've seen other people use a little camera lens that attaches to their iPhones to take a picture of moles so that they can look at it more magnified, whereas a dermatologist uses a dermoscope. Now, for a family physician to use a dermoscope or to spend the money for a dermoscope is just not realistic. So anything that allows improved way of looking at a condition is useful. However, I do hear that comment in that people have the COPD-6 device and aren't using it correctly. So any tool in anybody's hands that isn't being used correctly or that has a higher risk for being used incorrectly, there's value in being able to document that and make note of it and question whether or not the tool should be used. So very good points, and it's one that we will take back and have that conversation with a group of respirologists to say, is there benefit here, and collect some data around how actually the tool is being used. And it's part of what we're doing is that as we're building the EMR templates, we're actually creating data fields for people to enter in the values from the COPD-6 and enter in the values from the spirometry testing that results from the COPD-6 screening, result trigger that the spirometry is ordered. And so we'll be able to actually compare. We'll be able to actually build data on our own to look at how effective the COPD-6 is as a screening tool. So another answer to that respirologist is to say, great, great comment, great insight. Now let's build the data to actually show if what you're saying is in fact something that we should be aware of and should change our practice on. Data to inform our practice. So thank you. Is that a reasonable approach, Ranjit? Do you feel comfortable with that? Ranjit, we may have lost you.
Hear me now?
Yeah, I can hear you now.
Sorry. The respirologist did want to know the name of the physician that suggests the COPD-6 tool. I don't know if we're allowed to share data like that or...
So we just a second here, we won't get echoey. So it was Dr. Gordon Hogue that was involved, was the chief respirologist that was involved in the COPD module development. And there would have been a panel of physicians that were also associated with that and advising the trial of the tool. So Dr. Gordon Hogue was the one that was leading that. He's a respirologist, but I'm sure your respirologist will be quite familiar with.
Thank you.
Okay.
If I could just add to, only because I've had the question asked now a few times by some of you around if you know, would PSP Central be covering the cost of the device for modules? And to be honest, this is brand new information to me. I don't know too much historically about what happened, although I have been a few people did let me know that that was the case. So for any of you that are also wondering that, I'm going to be taking that back to our central team to figure out. This is the first time I've heard of it, and I'm sorry about that. So I'll be getting some more information and providing some directives to you guys on exactly what we'll be covering and what we won't be covering. So thanks for your questions about that.
Any other questions?
Hi, this is Ranjit again. I do have one more question.
Sure.
This module is very new to me, so I'm not sure, is there a billing code for the GP practices to try out this COPD-6 tool in their practice?
No.
Thank you.
One of the things that, and I think that's a great comment, and it had come up at the time of the module, and there was some attempt to work with the MSP and with the billing incentives group to look at whether or not this could be included as a lab test. And to my knowledge at this point, that was not approved, and that there was no further work that was being done on that to actually develop a billing code that would support or cover the use of the COPD-6 test in the office.
Hi, this is Karen in Prince George. Could they not use the peak flow MSP code?
You can use the peak flow if you do a peak flow. So there is, as part of this, one of the things that is discussed is using peak flow meters, and many physicians use peak flow meters. So certainly if you're doing a peak flow at the same time that you're doing the COPD-6, you can bill for the peak flow. That's a very quick test if people aren't familiar with it, where there's a little, again, a mouthpiece, you blow into it, and different ways of showing on a scale, and it's a mechanical device, not a digital, showing on a scale what the peak flow is, or what the effort is in showing the force of breathing out. And there's a table that's included as one of the tools in the COPD algorithm with a peak flow chart that's showing what values you might expect to see in both male and female and at specific ages, and what the normal range is for that. So thank you for adding that comment, and that material is available in the algorithm. Any other questions?
It's Esther Bruce. I'm just wondering, is there an expectation that's new for GPs who are going to be taking this module and others, that in fact they do a panel assessment and cleanup before they do the module?
So as part of the panel cleanup work that you're doing with your trial physicians, if those people are part of this cohort, then they'll have done that. But there isn't an expectation that all that work will have been done ahead of time. And certainly my suspicion is that as part of your pre-visit, you got enough to do, and just making sure that the templates are there and that people are aware that this will be an expectation, that panels, the panel cleanup, in other words, identifying the registry of those patients that have COPD and heart failure, and making sure you caught all the ones that you might have missed, having a look at how that compares to provincial and or national prevalence data to give a sort of a sense of where the practice is at, is something that's going to happen in action period 1.
Great. Thanks, Bruce.
Any other questions? So we have an instructional plan for COPD heart failure that outlines how each of the 8 learning outcomes objectives would be addressed. And one of the things I wanted to touch on is the how to teach piece. And as I mentioned, Bill Upward has been very helpful at being able to provide a neat little tool, and it's certainly something that many of you may use many of these activities and be familiar with them, or have other ones of your own. And what I hope that this could be is a jumping off point for gathering all those active learning activities into one place. So what we have here is 2 pages of the kinds of active learning activities that you may want to do to have audience participation component in either this module or as you're using when you're working with small groups in the future. So there's things like questions, brainstorming, the think, pair, sharing, which is some may know as 1-2 table, or other different ways of, you think for a minute on your own, you jot things down, you pair up with somebody, share ideas, and then together you share the ideas with the table. Jigsaw, covering multiple topics. Lovely role playing, which everybody really loves. Mini writes are basically taking what you've learned, putting into 1 minute in a paper or 1 sentence summary. Informal quizzes, proactive problem solving, debates, pro and con grid, World Cafe, many of you are comfortable or familiar with that, and other options in there. So what I'd love to do is be able to take that list, which, as you can see from the bottom, there's all sorts of other things that people might try. We've introduced scavenger hunts in adult mental health that we could document and have available with these kinds of brief descriptions that then we could share as a central knowledge repository on how might you use active learning activities, good for both your presenters and or you to be able to have access to. So thoughts and comments on that? Is that something that people think is a good idea? And if you have some tips, tricks, tools, other ways of being able to approach this, we'd love to centralize them and then be able to share them out with everybody.
There's a question.
Okay, there's a question here. Hang on.
Thanks, everyone. I'm just going to read out. This question is from Ron. Bruce, can you bill for a peak flow if the COPD 6 does not give you that number?
So you can do anything. You should not if you actually aren't doing a peak flow and just doing a COPD-6, because the COPD-6 does not give a peak flow reading. That being said, to do a peak flow takes 15 seconds. More of the challenge is having the actual tool, the little device available in an office to be able to do a peak flow. Any other questions around the active learning activities? So hearing nothing, I'm going to assume that was a unanimous thumbs up and that everybody's really keen and excited about that, and that's just a wonderful idea. So I'm patting Bill and I on our backs because of all the wonderful support that I'm hearing. So I'm tongue-in-cheek, folks, so that's okay out there. Did I hear somebody start to say something, or were they just laughing at me?
No, it was, can you hear me, Bruce?
Yes, I can.
Okay, I just want to say this is a fabulous coaching tool.
Yeah, I think it's great.
Yeah.
And, you know, I think it starts giving us, when we talk about, you know, the percentage of a presentation that should be didactic versus being participatory, it's one thing to say that, and it's another to say, okay, and here's some things that we can suggest that invite audience participation, some actual ways of doing it. Try them out, see how they work with you.
I agree. An excellent way of moving it into the didactic direction for coordinators and coaches. Great.
Good. So from there, we're moving into the actual learning sessions and starting to build the agendas for each of the learning sessions. And that's just what the intent is of this part of the document, which then moves into your actual agenda and talks about the time allocated and the delivery format. Again, this isn't meant to be prescriptive. This isn't meant to be a recommendation. This is an option or to offer you some suggestions that you can modify. I think the key thing, though, is that we are constrained by the College of Family Physicians in that we are granted the CME credits based on the agenda and the content that we supply to them. So if there are presenters that want to deviate from this and do deviate to a marked degree, you have to be aware that that may then invalidate the CME credit if their course, their presentation was to be audited. So I'm just adding that in as a reminder for people, because the practice in the past has been to sort of generally co-develop with the presenters, take the material that came from PSP Central, which in many cases, I've got to admit, was not adequate to sort of be able to translate from train-the-trainer sessions to actual 3 modules. And child and youth mental health is a classic example of that. So we were forced to, in many cases, work with the presenters to really almost develop from the ground up a whole presentation. And the attempt here is now to standardize that, allow variation, but within a framework. And I know that for many of you, and certainly knowing from my own perspective and experience, this is a departure from what we're used to doing. So I'd be really interested in if people have any comments or want to have any discussion about that point, because there is now an expectation that you will follow this a bit more closely, but still allow some flexibility. So thoughts or comments on that? It may be new or different, or it may be contentious. So
again, I look at it with welcome relief. It's really nice not having to do as much planning with the GP champion and the specialists because you've laid it all out, and there's no, there's not as much need to present alternatives to didactic learning and why it's important. You've got it all down here, so I'm actually really thrilled.
Good. I'm glad to hear that. I know from, again, experience how much time was required from me to work with any one of the regional teams that I've worked with a number of modules in actually developing the whole presentation and the agenda. And so certainly for me as a physician, I was willing to do that. But each time having to do that, it was starting to wear a little thin for those that do a lot of these types of things. So from my perspective, I think the two key things are it reinforces that there needs to be physician buy-in. And, you know, Ranjit raised something that I think was quite key in that the respirologist that was involved questioned one aspect of it that takes a fair bit of time. But I think that that type of feedback and that type of concern is a legitimate one that deserves Central to step back and say, okay, we better take a look at this and see what the evidence is, how this is being used, and understand what the consequences are of us teaching it, as opposed to somebody else that says, you know, no, I hate quit now. I'd much rather use something out of Arizona that works 100% of the time, and it involves needles injecting into a space right behind the left ear. You know, those are the types of things that we want to be careful of, that we don't encourage departure from evidence-based management teaching, and make sure that everybody understands that this content and the materials resources have been quite carefully vetted, may be updated with time, but should be something that at the current time with our current knowledge should be something that is generally supported for all physicians.
Hi, Bruce?
Yes.
Can you hear me? This is Jane from VCH. Thanks for this. This is a really well laid out document that you're displaying. I just have a question. Actually, it's in line with the whole quit now and evidence-based. We haven't run a COPD module recently. However, in the previous ones that we have run, because of the prevalence of the e-cigarettes and the vaping, I'm wondering if there is an ETA on whether or not that content will eventually make it into this module as part of the core, because it is something that we have time and time again been asked of by our participants.
Thank you so much, Jane. I mean, it's just wonderful when we have modules where people just want to plunk us right into the midst of controversy.
Sorry.
Well, you know, I'm sure you've all been reading a lot of the things that are in the media about e-cigarettes, and it's a perfect example of a controversial management strategy that we are getting mixed messages on. I think the challenge here, and the interesting thing is, much like what we did with marijuana in the pain management, is use it as an opportunity for people to have a discussion with the best evidence that we can provide, but that we abstain from actually making recommendations or suggesting that there is some clarity in some of the guidelines around the use of these things like marijuana or e-cigarettes, or I'm sure there's other examples and other things. I think because it's something that's on people's minds. What I, as a physician, appreciate most is that if there isn't something out there that's definitive, tell me that, and give me the opportunity to have a conversation with my colleagues on the topic to find out what they're doing and what their approach is. So it's a great thing as an option in learning session 3 to be able, there's time built in there for these kind of places that conversations can go, and offering that menu of choices to the audience to say, what are you guys interested in talking about at learning session 2 for learning session 3? There's a great example, Jane, of something that maybe that the group will want to talk about. Now, the add-in that I'll have on that is that if you do it, and if you're going into a topic that you don't see us from PSP Central having any information on, we would love then to have you be able to provide us the content that you used and the feedback that you had from the session to be able to put it and make it available again provincially for all the other groups to sort of look at and say, here's one more thing I can add to my behavioral menu of options that I can offer to physicians to see what they might like to talk about at learning session 3 or in a separate small group learning session. It's a jump-off point. So thanks for that.
Fair enough. Thanks.
I have a question.
Sure.
Hi, everyone. I'm just going to read a question from Esther. Bruce, could you explain more about the bottom assessment area?
Okay. Basically, what that assessment is for you is some ideas for you to get a sense from the audience it's a reminder more than anything of how did the learning session go. And some of the things that you can see are repeated, and that was sort of intentional and a carryover, my apologies to some of that, a carryover from the adult mental health. But use that as a reminder to do a bit of a survey about how the actual session went and what useful things came out of the session itself. And I know that for the most part, you're all doing that. As a presenter, one of the things that I found really useful was when I had timely access to the results of that survey, and I got feedback on not only what parts of the content were understood, were useful, were meaningful, practical, but also how did I do as a presenter, and what parts of my presentation were effective, what parts were ineffective. I think key to doing that, and if you're doing that especially with a new presenter, is that rather than just sending them the evaluation and saying, here's the evaluation for your presentation, you know, I can remember getting one that I did with one group that basically said, we really don't appreciate being talked down to. You're talking to us as if you would be talking to a group of residents. You know, you should go back to teaching residents and medical students. And, you know, as an experienced presenter, I go, okay, that's one person's opinion. That's something I wonder if there's something that I'm doing or at one point that sort of got them going on that ladder. However, with an inexperienced presenter, that could have been devastating, and it could have been something that they took and said, you know, I'm never going to do a presentation again, thank you very much. So I would really encourage you as RST people, coordinators, that coaching your presenters is part of your job. You've seen many presentations, you understand the kind of feedback, and you can use that as a coaching opportunity for your presenters. And so make people aware in the beginning that what they're getting into will be to also have the opportunity for some self-reflection on their presentation style and skills, and that it's constructive, and be able to interpret the information that they're getting in a way that is not ego damaging.
Thanks, Bruce. I just wondered, are the provincial evaluations that are being tested for the modules being applied to the COPD module?
Provincial evaluations, what is?
So there's been a working group on developing standardized learning session evaluations. I'm just wondering if this is part of what you're talking about, and
do you know about that?
Yeah, it's partly. So yeah, that's something that Aaliyah is leading in with the expectation that I think it will tie into all of.
Hello?
Maybe I asked something I wasn't supposed to. Hello?
I've lost contact audio, but now you're back.
That's just Esther. I'm just wondering if Bruce is cut out.
Oh, okay.
Yeah, I hear you guys. You just can't hear Bruce.
I'm sorry, everyone. What happened was that we were muted.
I asked a bad question.
Oh, we're back. We're back. The short answer, yes, I was probably taking too long to respond. Yes, I'm aware of it, and it's tied in. I think that the timing of it, though, will coincide with probably some of the first modules that will come out around COPD, but the intent is that it would be used for all of the PSP clinical content areas, so any of the module work. Is that all you were asking, or are there any flags? I'm just not sure if you're kind of thinking there's any flags at this point, because if there is, please let me know. I'm not fully aware of the details of that, but I do know that the intention is that it would be used. So please, if there's any concerns or detailed questions around that, let me know.
No concerns, Christina. It's just having us all use the same evaluation form at the end of learning sessions, I believe, was the idea. So if there is a provincially developed one that's going to embrace the questions that Bruce has brought up in the assessment question here, that would be great.
That's a good question. So I'll make note of that and check in. I haven't been really closely tied into what she's doing, although I know that there's been a group of you presumably out there that have been helping inform that. So I know that once it's rolled out more broadly, of course it will be sort of, you know, I'm sure that we'll have the ability to change as we go, but I will flag that and ask that exact question. Thank you.
Thank you.
So just to comment about the actual learning session agendas here, you can see in the delivery format that what we've tried to do is add in the audience participation activities as suggestions only and options. And if you change them, have something else that works better, we'd love to know about it, as I mentioned before. But it's, again, just part of the agenda as a reminder to work at that audience participation. The temptation is we've got time here, we can bring in more content, we can bring in a specialist to talk about this or that or whatever. And we know from the data, the literature, that the more material you present, it certainly may capture people's interest, but the less likely it is to actually be embedded in their knowledge base, their workflow, and less likely to be sustained. So the more they practice and think and talk about what they're learning, the better off the chances are that it will persist into their practice and over time. There isn't much that I really wanted to say about the actual presentations other than, again, as I mentioned before, the material is there. It's much better structured to fit what you will need for 3 learning sessions. Feel free to modify any slide with pictures or a slightly different approach. But if you do, please make sure that the general content is maintained at some point during the presentation. The slides tend to be quite wordy, and you can see that there's not a lot in the notes in there. That's intentional to allow you to be able to shift some of the words into the notes and replace it with pictures, and to give the presenters some sense that they aren't just taking something that's completely prepackaged and they're being forced to follow along. I'm involved with a series of webinars from CCMI that we're doing at lunchtime that the ministry has made very prescriptive, and as a presenter, it's a very strange feeling to be forced to read off the notes and be only able to use a certain slide. So there's leeway in that if the content could be presented in some way, whether it is as part of a handout, verbal, on a slide, in the notes, is really up to the presenter, and how it specifically is worded, encouraged to be in their own language. So that's my comments to that. I just wanted to touch on one final thing, which is to look at the algorithms, because they have changed to some degree. Some of it is based on the work that was done by Dr. Varani and some of the new things that he's stepped up with, and also some of the work that's been done in the interior with COPD and some of the things they've learned. For the COPD algorithm, the front page is really unchanged. There are links to various items, and just let me get rid of that, oops. There are links to various items that are part of the COPD algorithm, and especially the acute exacerbation plan. I was just at the GPAC meeting, which is the Guidelines and Protocols Committee meeting yesterday, where the COPD guideline is in its final stages of being evaluated and released. And there will be links to some new material for the acute exacerbation plan, which is a flare-up of COPD, and for antibiotic treatments that will be available once that guideline is released. My expectation is probably later this year for the final product to be released. The other pieces in here are, as before, linked. There's definitely some new material in there that is just a bit better laid out and a bit easier to read. Certainly the information that's on things like the COPD-6 screening tool have been modified so that they're easier to read and have all the information in one place. And according, to what comes out of what Ranjit has brought up, we'll let you know if that changes. One of the points to that is that while we will set a cycle to these module reviews, if there is anything big that comes up like that, Kelsey and I are committed to making sure that those don't wait for a cycle, but that will be introduced at the time that they happen. You'll also see in here that there's referral forms, and the intent of them is to be generic. You can see they're unlabeled, and they contain most of the elements that should be required for a referral for that program. Be aware that that may not be the form that is accepted in your region, and you may have to replace that with a form that is appropriate to either your community or your health authority region. So that's my only caution there. We're working on standardizing that provincially through other committees that work, and so unfortunately we can't dictate what people should or shouldn't use. But we are encouraging the EMR vendors to use a standardized form in their EMRs because it's impossible, especially with COPD, to get the EMR vendors to embed a form that's specific for every community or every region. According to what I understand in my conversations with people provincially, is that there is a requirement for any region to accept any form, and as long as it contains the elements that are required for proper patient identification and to carry out the investigation. So if there is resistance to that, we'd love to hear about it. But just that's my only caveat in this algorithm for COPD. And that goes the same with spirometry form, the testing, and any other investigations that are used in there. Questions?
Hi, Bruce. This is Ranjit again.
Sure.
I really like the slide deck. Yesterday we went through the slide deck both with the respirologist and the cardiologist, and that was the old slide deck, and they could see a lot of gaps. And today, as we've just gone through it very quickly, I can see a lot of the questions that they asked yesterday have been already addressed.
Good.
So my next question is, when will this be available to us? When will it be posted on the web page?
Well, it should be on the web page now, Kelsey, or is Aaron still working on that?
Yeah,
okay.
So we have Aaron Picard, who some of you may or may not
teach them how to review when we're reviewing. I want to use it more as a talking point. So it's more of a how to explain. It'd be nice to have everybody for that. Because you're in drug screen, like, just show the
yeah.
Right.
Yeah.
And and then the hope with the action plan here would be
I was muted again. Oh my gosh, Ranjit.
Yeah.
Are you there? Okay, sorry. I was just answering and I was on mute again. I need to stop that. Bruce, I have an echo going on back and forth, so I keep muting myself. The answer to your question is that we're in the process of updating all the materials right now on the website. And so Erin Picard, who some of you may know now and have met virtually or in person, she's filling in for Caroline McGuckin. So she's the person that is doing all of that updating. And she had indicated to me that it should be done by tomorrow afternoon, and you will know when it's complete because you will receive an email from her just letting you know that all of the links have been updated and that you may now access it all. So just watch out for an email from her going out to all of the listserv, letting you guys know when everything has been fully updated.
Thank you. That's great.
Yeah, no problem. On a related note, I just wanted to remind you, a few months ago before Caroline left, we had sent you guys some information about a new online sort of change request form mechanism that we had been using. So it just occurred to me that as you guys are coming out there, and I have no doubt we'll be getting questions and feedback, I just wanted to do a little plug for that. The most effective way for us to be alerted, all of us to be alerted to your question and figure out the best way to triage it kind of within our own team is if you can submit your questions on that form. And I've just sent a little reminder for myself. I know that some of you are actually fairly new to our regional support team, so I'm going to send some follow-up information about that, so it'll have the link on, here's where you click if you want to submit a question.
Okay, Bruce back here again. So on the heart failure algorithm, the front page hasn't changed very much, but the part that has changed quite significantly is this page, which has to do with the pharmaceutical management. This is what the old one looks like, and I'm just getting the new one up here. Sorry about that. I thought I was right at the new one. There's been some cross-pollination and some contamination of some of the stuff that I've done with one file over another. My apologies. Okay, new algorithm right here. With the new one, you can see that it's a very different looking medication treatment algorithm. And there is one new medication that may come up. I think one of the key things with, just for you to know with the medications for both COPD and heart failure, that I think this is a place from a family physician point of view where having a specialist be able to present and speak to the medications would be very valuable. So as a practical point there, if you can't have a specialist live, even working with your region or even with provincial specialists, to have somebody talk even via a video conferencing or something like that would be quite valuable. A lot of the, especially the newest medications, are things that the family physicians may not be either familiar with, or even if they are familiar, may not be comfortable with speaking to. And especially in heart failure, there's a new medication called Entresto that is very new for people, and I'd be very surprised if there was much comfort around speaking to that. So this is all built into the algorithm, that there is information if you're absolutely desperate about a new medication such as the Entresto medication. And the trade name is there only because the generic name, and there's only one of that medication, is a bit difficult, and people likely will not have been exposed to the generic name and would know it by its trade name. So it's a slight departure from what we normally do by not including trade names that is here in the algorithm, but only mentioned in that first line, and all the rest of the reference to that medication is its generic name. So that's just in there. And there is a lot more patient information and physician information about this medication that's available through the Heart Failure Network site, or through myself if that information is required. And it may be possible that there even are cardiologists that don't have all the up-to-date information and patient handouts for this medication. So it's a complication and a bit of a challenge with what we're doing, that sometimes we're actually presenting something that may not be in the mainstream practice, but certainly is something that is front and center and evidence-based, as opposed to, say, something like the COPD-6, tool. So I'll pause and see again if there's any comments or thoughts or questions. And hearing none, the final thing is that there's some challenge to each region being able to make these algorithms relevant to their region. And certainly in the past, people have made requests to me and to PSP Central about being able to individualize their algorithm so that it reflects either referral forms and or resources for their region. I think some teams have hoped to be able to develop their own means of adapting these algorithms. And I don't have any problem with that as long as everybody is working from the most current algorithm and sending it back to PSP Central so that we're certain that it is the current algorithm that you're working from and updating or modifying, and that we're aware of that and we can share it with others if necessary. And if you haven't developed your own process or people to do that, again, putting a request to me, and I think from those of you that have done that, you can verify that I'm generally pretty fast at getting back to you with whatever adjustment is needed. And in some cases, your suggestions or requests have meant some fairly significant changes that help it happen in the algorithm that then go out to everybody. And I think that's the intent here, to make sure that we all benefit from what each of us is learning and or doing.
Kelsey, do you have anything to add?
Yeah, thanks, Bruce. I would just add, agreed that, yeah, we do understand that sometimes, there'll be the ability in certain areas to kind of gather some of those really pertinent and useful forms quickly and want to reflect that on the algorithm. So we just ask that that we kind of facilitate the process of actually updating the documents through the central. So again, just another plug for the change request, online change request form. So again, I'll be sending out some more information about that after this meeting around the link to use. And as Bruce mentioned, we will be, we'll make sure we're quick about responding. And also, I just think it benefits in the sense of sharing and learning, and also from just sort of the ability to maintain sort of that provincial level of evaluation and understanding of what's happening with regard to the core or the key forms and tools.
So leave it on, Kelsey. That's good. So that's everything that we wanted to present today, and I hope that's been helpful to you. Any comments, feedback, suggestions of how we could improve what we're doing, what we might have missed would be great. We have 12 comments that Kelsey has caught, and we probably should distribute those.
Yeah, so I've taken some notes here today. Thanks, everyone. So I'll probably just draft up a little bit of an action email. So I'll just let you know how that's working. Some of them, of course, will get a little bit of time to need to get the responses for you, but I'll make sure that I've got I've captured all the questions, and then, of course, if I've missed anything, you can add to them.
And the only comment that I see here, and I'm smiling at, is dyspnea. Dyspnea is spelled the American way or the British way. And the British way is an O before the EA at the end. And either is acceptable. But we will look through our content and make sure that it's standardized to one way or the other.
Thanks, Esther. Very oriented.
Oh, nail me again.
No, it's good. It's good. Thanks.
This is great, everybody. Thank you.
Yeah, thank you. So we're over a half an hour early, but that's great. We weren't sure how long it was going to take, so that's okay. We'll let you guys go and get some of your morning back. So just a couple things. One, this meeting has been recorded, so I will also make sure that this gets posted to our PSP Divot site, and I'll make sure that that link goes out. And we'll send you guys a little recap of the notes from today. And as always, Bruce and I are here for any other follow-up questions. You know how to reach us. So thanks so much for your time. Thank you.
So, Pat, no C code. No C?